John Daly, LCSW KDAC 2, is the founder and clinical director for Recovery Happens Counseling Services and specializes in the outpatient treatment of adolescents, young adults, and their families with addictive disorders and dual diagnosis issues. A recipient of numerous awards for his work, John is also the co-author of How to Help Your Child Become Drug-Free and Adolescent and Young Adult Addiction, the Pathological Relationship to Intoxication and the Interpersonal Neurobiology Underpinnings. John has been an instructor to nurses, medical residents, and has taught postdoctoral students for UC Davis. Currently, he instructs graduate students for the University of San Francisco and is the developer of a chemical dependency track within a Sacramento-based psychiatric hospital. John has trained thousands of clinicians working with youth, young adults, and adults. He has been a resource in the media over 90 times in his career, from local media to the national Today Show. In addition to teaching, practicing, writing, and providing forensic testimony, John provides program development, trainings, and conference presentations. For more information, go to recoveryhappens.com or call 916-276-0626.
Hijacking me. Now I feel like I'm powerful. That comes from Terry Real out of the Meadows, one of the co-founders of the Meadows. So there's a lot of ways of looking at mood, but it's all affect regulation or dysregulation. So the goal at the end of the day is to help people regulate affective states. So what regulates affective states? Relationships do. Just kind of gave an example of that. Neurobiology does. And our internal working model, our psychology. Those three things are our affect regulating systems. You guys with me on that? Relationships, neurobiology, and our psychology. And it's always happening at once. So the question becomes, well, how is it that then Johnny has addiction and bipolar disorder? Is it genetics? Is it environment? That sort of thing. So where'd my wife go? Oh, she's taking pictures. So Dr. Angela Chanter and I, our program is a KPIC approved site, so we can take pre-doctoral interns and postdoctoral interns. And one of the questions we asked all the pre-docs at the time was, what is your understanding of the etiology of depression? What is your understanding in the etiology of access to personality disorders? What is your understanding and etiology of addictive disorders? And everyone weighed in with the great graduate school stuff, right? And at the end of the day, the point we were trying to make and see how they're thinking is, and I'll just say it, everyone in this room has experienced depression at some time. Everyone in this room has experienced anxiety at some time. So if you all had depression today equally at the same time, what's the cause of your depression? Well, it's going to be different for every single person sitting down and eating right now, right? So the game is, I can't just go DSM-5 on you. I need to sit with you. I need to know what the 100-year-old family story has been for coping and negotiating relationships, and your own family of origin stuff, and then your elementary school experience, socially, academically, and how you felt in relationship to yourself, and any traumas along the way. And then in junior high school, which is a trauma for everybody, right? Junior high school, like, can we just sleep through? Wouldn't it be nice if you could go to sleep at 12 and wake up at 19 and just like skip all of that? So anyway, so what the game is uncovering and learning how to discover where people get stuck in their development. Misattunement creates stuck. Shame creates stuck. Abuse creates stuck. You name the abuse. Big T. There's little t trauma, which is misattunement and lack of empathy in a family, which we'll talk about. And there's big T trauma, which is all the classical trauma stuff. Those things get us stuck. And that's where my interest is as kind of an investigator, compassionate investigator, is where did this particular individual get stuck versus a silo of, it's the disease concept of addiction, because E.M. Jelinek followed hundreds of alcoholics and found they had 31 symptoms that progressed over time. And then later the AMA, then the APA, and the World Health Organization said addiction is a disease. And it meets the criteria of has symptoms, progressive, and if left untreated can be fatal. Totally get the model. But there's more to the story, and that's what we're going to flesh out today. So how many of you guys have heard of interpersonal neurobiology? Show of hands. This is great. So we're coming a long way. It's about half the crowd. I think it's the most comprehensive biopsychosocial model of understanding etiology, pathology, and treatment that exists today. So the roots of it are in attachment, and the father of attachment is Bowlby, John Bowlby. And here's what Bowlby says. We have to attach for better or for worse, because there is no such thing as a viable child. There's no kid that's walking out of the womb saying, all right, I'm going to school, I'm going to feed myself, I'm going to soothe my emotional state. It doesn't work that way. So affect regulation and dysregulation, yes, there's genetic vulnerability. What I would say is there's actually genetic vulnerability to stress. It should be called stress vulnerability, instead of like, well, these glucocorticoid receptors aren't working in this situation, and on and on. And I get into all the fancy neurobiology of it all. But I think it comes down, when we look at some of the genetic studies, I can't manage stress. Stress is simply good things are happening, bad things are happening, change is occurring. There's all kinds of stresses. So what Bowlby says, so there's that genetic piece. Now here's what I want to tell you, and this is where we have power with our clients, is we can't control much of the genetics, but we can rewire the way they think. We can rewire their neurochemistry. We can rewire their sense of trust in a relationship versus mistrust, approach versus avoidance, having a secure sense of self. That's where the work is, and that's what I want to talk about. So Bowlby, so when we look at addiction, mental health issues, yes, there's some genetic vulnerability, but for most of the clients we're sitting with, it was co-created from the experiences of their childhood growing up. How someone thinks about themselves, all that negative tape, that's not genetic. They weren't born with that. I'll talk to so many clients and I'll say, hey, I've been missing you. It's great to see you. I love what you have to say. You have a lot of offerings. This is how I see your offerings. And they're like, well, yeah, da-da-da-da-da-da. And I'm like, whoa, who am I talking to right now? Like, who is that? Like, that's not you. Who built that tape? Who am I talking to? So back to this Bowlby stuff. What Bowlby says is it's a biological imperative to attach. We need relationships. We need relationships. And it's the biggest regulator of emotional states that we have in our life. And if you know addicts, they're like, yeah, I'm going to do it yourself or I'm good. I don't need relationships. Talk to you later. I'm out. When we were little babies, what did we do when we were dysregulated? We turned to a relationship. We couldn't soothe on our own. We couldn't soothe. So we turned to a relationship, and co-regulation occurred. And in that co-regulation, when we were responded to, it built our sense of trust versus mistrust. I can trust my internal experience, my biological hunger pangs that I have when I take it to my caregivers and I'm like cry out because I'm hungry and they feed me, teaches me trust my own body. How many addicts and mental health folks are we working with that are disconnected from their body? I cited Pat Ogden earlier. She says, most people don't listen to their body until it yells at them. One of the gifts that I've been able to give to our children that are growing up is them listening to their body, teaching that at a young age. So back to how we get constructed. So growing up, we can't soothe ourselves. We can't regulate ourselves. We are affect dysregulated. Our clients are affect dysregulated. So the game is, how do we create affect regulation? Or how do we teach that or give them that experience? So when the caregivers are responding, That teaches them, I can trust my internal world. I could bring it to you and you will soothe me. If I grow up in an environment where I bring my internal world, it could be hunger, it could be that I'm bored and I want to play, it could be that I'm physical and I want to wrestle, it could be that I'm highly intellectual and I want to intellectually joust with you. You know, kids are bringing this all the time. The places where we meet them are the places they integrate. They allow that to be part of themselves. Because what it says here, we're going to attach for better or for worse. And if I have a caregiver that's like, I don't like your curiosity, I don't like your sensitive side, I don't like your physical roughhouse side, I don't like your artistic side, we're going to split off from that because our number one priority is to stay attached and stay connected to our caregivers. Are you guys with me on that so far? Okay. I'll give a little illustration. So here's the picture I've been using for too many years. I got to update my graphics. This is a model of the caregiver, and then this is the model of us growing up. As therapists, we take on this role. We're trying to reprogram. So this is the capacity of the caregiver, all these rays. And this is the capacity of a child, like all this capacity. So I already spoke to it. One need is hunger. Caregiver has capacity for hunger, to feed. That happens, it gets integrated. My other capacity is I'm artistic. Caregiver, capacity for, you know, the right brain, the right hemisphere of your brain gets integrated. I'm emotionally porous, relationally sensitive. If caregiver can pull that off and mirror and meet that, that gets integrated. The stuff where they can't meet us doesn't get integrated. And then so let's say their capacity is not like that, but is only a couple of rays of light. We will split off from all those other parts of ourselves and do whatever it takes to stay in the light of the caregiver. You with me right now? That is messed up. That is the development of affect dysregulation, not regulation, of insecurity, of disconnection from our body, our wants, our longings, our desires, all kinds of things. And now here's the next step that makes this even deeper, and that is we grow up with somebody that we actually have to attune to them and mirror their needs and take care of them and take care of us. And that is the etiology of codependency right there. If you need an explanation on how codependency gets developed, it's what I've just been saying for the last 5 minutes. And so I wrote an article on that was published nationally. It's on our website under newsletters. So you guys with me then on that then? So that if the caregiver is alcoholic or depressed or narcissistic, or it doesn't have to be all that. It could be 2008 and I just got born to this family in 2008 and my parents just lost their job because the economy crashed and grandma's dying, so they got to take care of grandma. They got to move to the Midwest for a new job off the West Coast. So we're not trying to pathologize. It's just life happens. Life can happen. So anyway, but that's a way to think about, like, there's a lot to the psychological development. Right there explains how we get insecure. Big T trauma, that's small t trauma. That's trauma that needs to be talked about a lot more. This is trauma we flush out all the time because we happen to work with a lot of high SES clients in my 20 years, and they all say the same thing. When they start getting connected to the pain of family origin stuff, they're like, I feel like we were disconnected. I feel like there was no real true connection between my parents and I. And here it comes, ready? But they wanted what was best for me. They sent me to the best school. They bought me the nice stuff. But I have some sadness that there wasn't the connection. But they wanted what was best for me, right? So that's in and out of connecting to it, defending it, connecting to it, defending it, on and on. Any questions about that so far? Yes. What's socioeconomic status. All right. So I think I actually spoke to this already. I'll skip that slide because we don't have a whole bunch of time. Small t trauma. I shaded it where it's hard to read on purpose because it's easily ignored. Small t trauma and then big T trauma. What we know about, I'll give you the small t trauma. You guys all familiar with shame? You remember John Bradshaw back in the day? Shame, shame, shame. He was onto it. I think what he didn't know is there's a lot of neurobiology connected with it. So now here's the neurobiology of shame. And not shame used as a weapon that he was talking about. Like, shame on you, you get out of my face, da-da-da, you upset me, you ruin the image of our family, you da-da-da-da-da-da. That's louder. That's used as a weapon of control. I'm talking about small t trauma, which might be news for you guys, of misattunement. Now you're going to do misattunement 40% of the time anyway, so don't try to be perfect now. And don't walk out of here with your head down and all that kind of stuff if you're a parent today, because I got 5 kids, so trust me, I'm in the game. Misattunement is that you don't meet small t trauma is the child grows up and emotionally no one's connected to their internal world. My son comes up to me and says, "Dad, I'm bored. I want to play. I want to connect." And I'm like this on the computer. "Hey man, come back later." That right there is misattunement. Is that going to create a trauma right then? Probably not. But it's probably not a one-time behavior that dad's going to do. And it's probably going to be consistent over time. So what starts to happen? He comes in with joy. Maybe he can connect with dad, and maybe his needs will be met, coming all in. And then he gets shut down. And then what happens to his body? Goes the other way. Small t trauma. What we know about misattunement creating shame is 3 things happen. And this might be news for some of you guys. It's in my book. When small t trauma shame occurs, it activates apoptosis, which is a biological word in microbiology for programmed cell death. It activates apoptosis, programmed cell death of the dopamine system. Dopamine system. That dopamine system is developing. Now, if you are addiction treatment professionals, that you got your ears went up when I said dopamine, right? So the dopamine is the reward center. It's the mesolimbic system. It's the hedonic system. It's the pleasure center. And that system, that ability, that the development of that neurobiology over time in that family household is going to contract and break down programmed cell death of the dopamine system. And that's coming out of the David Geffen Medical School at UCLA. So that's a news for you about shame. Now what's tethered to that? So we got a relationship, interpersonal neurobiology. We have a relationship that now destroys the dopamine. Now what's psychologically tethered to that is I don't want to be seen. I want to be unseen. And my sense of trust versus mistrust in relationships, should I approach or should I avoid? I mistrust and I avoid. You guys with me on that so far? Making some sense to you? You could already see where you could add to your developmental histories when you're asking all the questions and watching, hearing how they're growing up and how they're operating in the moment, like how informative this can be. So that's the dopamine system. Now here's just on the dopamine, just so you know, because now I'll just say it because most people are taught that dopamine is everything that I said. There's more to the story, and Jacques Panksepp has been talking about it for eons. The dopamine system is also the I want system. It's the I want system. It's desire, it's passion, it's craving, not in the sense of drugs, but it's the desire, it's the I want system. You get what you want, it fires again on the back end, and that's the reward system. All right, so there's one example of interpersonal neurobiology affecting the development of dopamine, which our clients are chasing after on the streets with drugs. And I should fast forward on to something else. Oh, perfect. We are in an opiate crisis. We have been since 2001. It just showed itself bigger 6 years ago with OxyContin, but it was around way before that. And now it's showing up with heroin, right? You guys all aware, and fentanyl. Fentanyl's a beat down. You know what's sad about the fentanyl thing? In Sacramento 6 months ago, we had 40 overdoses, 20-something people died in a couple of weeks from fentanyl-laced Norco. And I did 7 different media interviews with 7 different media sources within just a couple of weeks. It was a slam, it was a beatdown. They're like, what the heck's going on? So then we finally learned what's going on. This is how bad it gets on that story. We learned that there's a synthetic form of fentanyl coming from China down to the Mexican cartel. And in Mexico, it costs 20 cents to make a pill. So they're taking this drug, pressing it in, mixing it into what would be Norco or Vicodin, selling it on the streets as Norco or Vicodin, but it's dominant with this synthetic form of fentanyl, and then they overdose. Well, here's how sick it gets. You know what the state of the heroin epidemic is today? Heroin addicts want fentanyl in their heroin now because it's more potent. And the closer to death that you are on the high, right? If you think about the peak of intoxication, if this is the peak of intoxication and this is death, you want to get as close to that peak as possible without dying. That's how, I mean, that's the sick illness, right? It's that, but that's what the demand on the street is now. We don't just want heroin, we want heroin with fentanyl in it. So that's a national epidemic. Now, let me ask you guys this. This is the question I ask anything that I'm talking to you guys about, we're practicing on a daily basis in my program. So there's nothing that's just intellectual, academic, theoretical stuff. If I get too intellectual and academic about it, or it feels academic, say, John, can you give me a real life example of how I could use that in my practice? Because that's how I want you to get it. With this here and what I just said, when the OxyContin addicts were coming through the door, I would ask them and their family this question that I'm going to ask you. Hey man, so you're jamming up the opiate system every day, snorting it, smoking it, and shooting it up. Do you know what the opiate system was built for? Do you have a sense of that? Because you're like pouncing that thing every day. So I ask you guys, what is the opiate system for? Huh? You can't answer this. And you've been to my training, Shelby. What is the opiate system? Pain. Someone said pain. Is that what you guys said? Managing pain? See, somehow my position up here has created a sense of fear and shame for you guys if you get this wrong. Now, if you have insecure, preoccupied, anxious attachment, I will tell you this. I just really need you guys to try for me to feel okay, all right? Can you please help me out? And you will lean into helping me out. The opiate system, when you look at attachment, when you look at connection, the core neurobiological underpinning of connection and attachment is the opiate system. There's a line in my book that most of you have that says, addiction is a consequence of and a solution for failed relationships. Addiction is, mental health is, a consequence of and a solution for failed relationships. If I had failed relationships in the beginning, my affect regulation system, biopsycho and social, is not going to be developed properly. So now I'm going to have mental health issues or addictive issues to rebalance all that stuff. The opiate addicts, so it's the core neurobiological underpinning. I want you guys to do this. How many of you guys are treating opiate addicts right now? Yes. And I want you to call me out on this if I'm wrong, because I have a lot of confidence, because I have a sample size. I'm not arrogant. I just have N equals 200-300 examples of this. And here's what I want you to do. Wait, first let me ask you guys, have you guys ever been with your people? You know your people. When you're talking with them, you're connecting with them, you just feel energized. There's no place else you'd rather be. Your people. You guys relate to that? You know what that is? That's the opiate system firing as a result of a relationship. That's all that. That's the neurobiological core underpinning opiate firing from mu and kappa opiate receptors. That's reinforcing that feeling of attachment because it's all flowing and working the right way. So, here's the test that I want you to do. I want you to speak to this with your clients. This is what the opiate system is. It's the core neurobiological underpinning of attachment. And they'll be like, all right, that's kind of news to me. But I will tell you this, secondly, and this is where what we try to strive for in our program. Information doesn't help anybody get well. Information, saying all this, it's going to feel exciting for you sharing it because it's something new, but it's not going to get them well. Now, it's important, but information didn't create the injuries. Information's not going to fix the injuries. Experiences are. Experiences created the trauma. Experiences create the wellness. So here's what I want you to do. You're going to explain this intellectually, and when you have that moment with that client, have you ever sat with a client and you had that experience of there's nowhere else I'd rather be because there is a flow happening right here, right now that is energizing, and maybe I should like my family more and everything, but I just kind of want to stay at work right now because this feels really good. Have you had that? Yeah? That is the opiate system firing as a result of the relationship. So when you're sitting with that opiate addict and you've explained this, it might be session 1 that you explain this or 2, and somewhere down the road coming up soon, you're going to have that energized moment with that addict. And now you get to translate this intellectual stuff to a real life experience. And you say, man, this experience of sitting here right now and seeing you really flow and me really flow and we're connected and just kind of all this like just, you know, vulnerability, connection, discussion, truth sharing. Hey man, this is that opiate system firing as a result of a relationship faster than an injection of heroin and with less side effects. And if you had the choice, here's the risk. And if you had the choice of going home and shooting up right now or staying in this relationship and learning how to find more relationships like this, which would you rather do? Now, you know the first time I asked that question, I'm like, I just set myself up for all kinds of bad. They've all said, I'd rather have the relationship. Take the risk, people. You know what I'm saying? Like, take the risk. I'm not lying to you. The sample size is too large. It has to be authentic, though, right? Don't just make it up. Don't just try it on. Explain that the opiate system that they're chasing after is the neurobiological core to attachment. And when you guys feel energized in that relationship, speak to it so they know what they're feeling and where that's coming from. And that there starts to inform the treatment plan. Well, dang, we need to learn how to approach relationships, not avoid. We need to learn how to trust relationships, not mistrust. Well, there's a year of therapy right there. And it's no joke, right? Like, sadly, it's like no joke. I teach graduate school in the MFT program for USF, and the dean last year said, hey, we need to focus more on 7-session CBT because that's what insurances are paying for. And I said, in my 20-year career, I've never gotten anybody well in 7 sessions of any modality. You know, like you might put a Band-Aid on, but they'll be back next week. But are you guys with me on that experiential? Give it a shot. If it doesn't work, give me a holler, and I will consult with you on that until we make it work, you know. So keep that in the back of your mind. Now, this slide, and if you don't have the handout, because I know it was kind of confusing, that last minute e-blast that I sent out, which said, hey, Thursday, when it's Friday, and then click here for the handout. Anyway, if you don't have the handout, I will email it to you. 3 times now, going over this with clients that I'm going to go over with you in a minute. Going over this with clients, there's been 3 cases now where the client says this: I've never told my therapist in the past. I've never told my other therapist in the past. But I was molested by my, and you name the person. Because it's never a stranger, it's always someone you know. So, here's what I want to tell you. We talked enough about small t trauma as a result of relationships and how that affects the dopamine system and on and on. Big T trauma, when big T trauma occurs, there's a lot to what it does to the brain as far as trauma. Bessel van der Kolk, Bruce Perry, MD, lots of people that can speak to that, and you could read about and you'll hear at other presentations. I'm just going to speak to a small one that's tethered to addiction. What happens for those folks that get big T trauma is there's a part way down here in the brain called the locus coeruleus that fires noradrenaline. And noradrenaline is needed for our heart to beat and our breathing to occur in our lungs. It's, regulating organs. The lower in the brain, the more important it actually is. I don't need a prefrontal cortex to ponder the stars and astronomy and physics. I need to be able to breathe and have a heart that works. So the lower, the more important. When people have big T traumas, there's a part of the brain called the locus coeruleus that overproduces noradrenaline. Heart rate by default baseline is higher than everybody else's. Hypothalamus, reactive. Sympathetic arousal of the, versus parasympathetic tone. You put, like if you guys remember Ainsworth's strange situation study, you put a baby in a novel situation, if it has secure attachment, its heart rate goes up, like everyone's would. It seeks out the novel item and goes back. Heart rate goes down. For these folks with big T trauma, their heart rate is up. And you put them in a novel situation, it goes higher. And then you get them out, it comes down, but takes longer than it does for normal people, and it never goes as low. What's really interesting for the big T trauma folks that have this going on in their brain is when they use opiate drugs specifically, it stops that from occurring. Stimulants don't. Stimulants make it worse. Marijuana doesn't. It maybe takes the edge off for a second, but it's the opiates. And what it does is this overproduction of noradrenaline is there. They use the opiates. The opiates build a dam and put a wall right there. Now here's the challenge. As they're using opiates, this locus coeruleus is going to, for anybody now, not just big T trauma folks, is going to try to compensate and produce more and more and more and more. And then as good interventionists and clinicians were like, stop using opiates, stop using opiates. And then they stop using opiates, that dam falls and the lake of noradrenaline kicks in, and that's what opiate withdrawal is. Puking, diarrhea, nausea, achiness, sick, flu-like symptoms on steroids for a week. So that's what that is. And then we got Vivitrol now and buprenorphine and other things to help manage that. I will tell you that, on this note too, from Jacques Panksepp about the opiate system for attachment, he's doing some studies with mice, and he's got a new book out, The Archaeology of the Mind. And what they're finding is grief and loss is tethered to the opiate system as well. So when there's grief and loss, there's depletion of the opiate system for us. And then that drives us to seek relationships, to reactivate and rebuild that system. So the way they've discovered that is they get a bunch of mice together to hang out, and then they give some heroin, and the ones that are on the opiates go in the corner. They're like, I don't long and need relationships. And then they give other ones naloxone or naltrexone, Narcan, which shuts down the opiate system altogether. And those guys are like, I need a relationship. How's it going? So they start to actually try to seek to activation of that opiate system. So there's a lot going on with that I think we need to be explaining to our clients and then giving them the experience of it when it, and show them when it shows up. Any questions about that so far? Because this is now, I mean, you know, it's like I'm trying to keep it practical and applicable because that's how we practice with it. But I do get like it's kind of heady, and I do a lot of trainings in Sacramento, and we'll see the same people showing up year after year after year after year because it takes a minute. And also this lecture is on our homepage, recoveryhappens.com, bottom center. So I just want to make sure, yeah. Go ahead.
So, you know, in a residential treatment center setting, that what you're just describing happens all the time, right? So they remove the opiate and immediately get locked onto someone of the opposite sex or relationship, right?
Right.
And so I've worked at a lot of places. I've never seen an intervention that can actually pull them apart.
Right.
Help them focus, because really they're just filling it up with something else and you can't reach them at that point.
So they're filling up two different things. One is the opiate system, the other is affect regulation. And depending on where they got stuck in their development, psychologically and all these other places, they're probably patching those holes as well. I wrote an article, again, that was published nationally. It's on our website under newsletters on codependency. What's really interesting, and I think this is how I might lean into the discussion with them, is explaining codependency and how it could be harmful, and then the development of it, which we talked about with the sun shining down and whatnot. Codependency, what's tricky about it, is it's actually the one thing that comes closest to fixing the problem. It's not a drug problem we have. It's not a food problem. It's not a sex problem. It's not a gambling problem. It's not a, you name the addiction problem. It's a relational hole that we have that started in relationship and is now a hole within ourselves. So then, well, yeah, I'm off the drugs, and maybe they're seeking the relationship to activate that opiate stuff for sure. But the other piece to it could be that they're also trying to fill the relational void that's always been there that maybe they were trying to fulfill with the opiate drug. And it's just, you know, it's more discussion than factual, but those are the ways that I would think about it.
Okay, so how do I stop?
You have the discussion, and you have boundaries, and you find other ways for them to feel good. I feel like for me, when I'm in that opiate experience of, there's some of it, sometimes it's energizing, and then other times it's just very soothing, very comfortable. I would say hot bath. Take a hot bath. Go get in the hot tub. You know, get into your body. Get into your meditation. Yoga. Our program has yoga. Our Walnut Creek location doesn't yet because we don't have any clients yet, so we're asking for help. But we're an outpatient that will soon become IOP. We have yoga at our other locations because yoga helps with that for people. On the yoga note, there's a lot of research out of the University of Boston about yoga helping to build GABA, the neurotransmitter GABA in the brain, GABA aminobutyric acid. So we're always calling on that neurotransmitter in the brain to help us manage stress and anxiety. You guys were driving over here, you're like, am I going to be late? I have the computer glitch going on that creates stress and anxiety, you know, and then what happens is GABA kicks in and helps that get managed. Now, when someone's alcoholic or benzodiazepine addicted, that GABA system shuts off and starts to break down because it's all coming from the environment. So now we get them off the alcohol and the benzos because we're good interventionists and therapists. And now they're GABA deficient. Now there's GABA there's amino acids that are GABA that are helpful, and there's books about that. But we get them into yoga and meditation, and then even for some massage. You know, I mean, I've given massage tickets to clients. I'm like, you need to go activate parasympathetic system, you know. But that's what the purpose of the yoga is to help rebuild some of that. Offering them new experiences. You know, I've given this example a lot. You know, information doesn't help people, experiences do. Do you guys all remember the John Gottman research out of Washington? So amazing. He's like videotaping couples in an apartment, watching how stressed out they are, how their arguments are going, how they resolve it. And at the same time, they got measures on the skin, their heart rate, their urine's being tested. They have strips on their tongue. They're measuring cortisol. They're measuring everything they could possibly measure. And they're not trying to treat anyone. They're just observational psychologists doing research. And then one day they stumble across that when people's heart rate gets above 99 beats per minute, they can't resolve anything because they're flooded. They're hijacked by the amygdala. The flight or fight system's kicking in, and their prefrontal cortex of logical thinking shuts down. And they just stay in this circular argument and hash it out, and then it doesn't get resolved. Right? That's brilliant. 3 years, man. 3 years I was explaining that research to couples that I was working with in parent-child relationships. And I'm like this. So when you get flooded, you go for a walk. You go take a time out. And guess what I learned? No one took a time out. No one went for a walk. And I'm a slow learner. The information didn't help them. It didn't help them. So I explained the information to everybody, and I still do, but now it's different. When they're flooded in session, I'm like this. Thank you. Ding, 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 ding. And I'll tell you, the first time you guys try this, it's very weird and awkward and uncomfortable because you haven't done it before. And I just get ding, 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 ding in the middle of the argument. Ding, 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 ding. How misattuned is that? How unempathic is that, right? That's how it felt for me as a therapist. You guys are deep in your argument. I'm supposed to be the container to hold on to both positions of it, your emotional state, on, and I'm like this. Do your thing. Ding, 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 ding. And then I do this. Click the ding, ding, ding thing. Pass it along to everybody in the room. And then at some point, I'm like, oh, wait, what were we arguing about? And it gets resolved. Experiences is what we need to chase after. So I would challenge all of you, like I challenge myself and my staff, any intervention we're thinking of doing, how can we make it a relational experience? How can we do it with them? All right, Julie.
Question about that circle of, is that also known as the executive function, which a normal, healthy brain has the ability versus the infected brain that's in binge intoxication, satiation.
Yeah. So that, they're not operating. There's what's called bottom-up hijacking and top-down regulation. So for addicts, if we look at for addicts, what's going on right here? Here's the dopamine system right here. So bottom up, bottom is more powerful than top, right? Bottom is more powerful than top. So we'll just take Tiger Woods. I was using him for a lot of this a long time. Tiger Woods, rich, successful, on. And then Tiger Woods, like our clients, but just in different form, was like this. Yeah, I want to cheat on my wife and then have sex with all these people. That is bottom up, no executive functioning. So for a lot of addicts, there's some thought that the dopamine system comes up here and there's a missing link for this top-down regulation. We're trying to build that for them through mindfulness, through pause, reflect before you react. This here gets developed big time in early, it's the orbital medial prefrontal cortex on the right-hand side. Orbital medial prefrontal cortex on the right-hand side. So if you take this finger behind the eye from the side and this behind the eye on top, and where those meet, not left-hand side. We talk all this left brain. Right-hand side, where those two conjunct, is the orbital medial prefrontal cortex, which is responsible for like 10 different things. Empathy, reflection, on. There's a long list of how helpful that is. We're trying to rebuild that. How do we rebuild that? Meditation, yoga, but most importantly, our slow, attuned relationships. It's not 7-session solution focused. Rachel and I, my associate clinical, say hi to everyone, Rachel. She's the associate clinical director of my program, and we were sharing a case for a while that's done really well that Ricky Townsend referred to us. You know the case I'm talking about. She's got like 2-3 years sober now. 3 years? 3 years sober now. This gal comes to us. She's had it. Her first love, physically, sexually, emotionally abused her. Dad's alcoholic, mom's deeply codependent. Everyone wants to talk about the sister and not about her. She's had multiple suicide attempts and hospitalizations and gastric bypass surgery 1 or 2 times. Comes through deeply depressed. I mean, that's a complex case right there. You're like, do I want to take... If you've been in the field for a long time, this is one of those ones you're like, I don't even know if I want to take that one on. Because I could cherry pick the ones I get, right? Like, you know? But if you're new, like, you're like, let's bring it. Let's see what we can do, right? So I took it because Ricky referred it. That's why we took this case. And so some days I would see her, and I'd just go out in the waiting room, and you could just see. And I'd say, hey, let's go for a walk. And we just go walk down to the American River, which isn't far from our office in Fair Oaks. And what's tricky about this walk is it's actually downhill all the way. And then it's uphill all the way back. And then we got 2 flights of stairs to get to the office. And she's like, I feel much better. She did. Exercise is the most underutilized medicine that exists today. I know clinicians that have practices that are like this. If you don't exercise in certain ways, I'm not going to even see you. That's where they are. But, you know, everyone's got their silos. So then I had, for some reason, Rachel was taking over on the case because, I don't know if I had health issues or I was leaving town or something was going on, because it's always those things for me. Health issues, I got diagnosed with brain cancer 6 years ago. I'm good, but there have been times where I had to do chemo and it beat up on me or whatever, but I'm good. So Rachel then sees her and says, John, I had the best session with this gal. She came in totally dysregulated, and we did a meditation. And so we talked about that. But at the end of the day, and this is what Rachel and I talked about, at the end of the day, how much can you do walking and meditation until it habituates? It doesn't work anymore. Think about it for yourself. After about 3 days, after a week, how long until you need a relationship in your life again? You know, so that's where the work has been in a big way. So those solution-focused tools are important, but wellness is learning how to negotiate relationships again. And that takes a long time. All right, how much time do I have? Okay. I'll just give you a couple case studies. Actually, one's pretty recent. Jessica's right here. She and I were working with another Ricky Townsend referral. So if you guys need clients, get to know Ricky Townsend. I'm just kidding. She's blocks away from us in Sacramento. So let me tell you about Alex first. Alex was in the OxyContin heyday. Client I was working with, Granite Bay family, 22 years old. And I was working with this guy for about 4 weeks until we got up to a family session. And family comes in, and Alex says, so I want you to think about it, 1, as a clinician, and 2, as just be Alex. Feel this as if you were Alex, and what feels helpful and what does not. So Alex, oh my gosh, calls up on all this courage at some point and shares with his parents, leveraging off the secure base that he's developing in therapy with his clinician, myself. And he says to his parents, Mom, Dad, and they don't have a lot of communication. He's a gamer. He likes to game, and they'll let him game for like 17 hours because there's no disruption, right? Like, let him game. And so for years he's gaming, and then he doesn't have social skills and whatever, and he's using Oxy and Xanax and smoking weed. So we have this family session, and he says, Mom, Dad, when I'm in public, I'm scared with my friends. I'm scared to be in public with my friends. I'm petrified that if I move my arm when I'm near them, they might look at me. They might think that I have messed up hair. They might think that my clothes are messed up. So I'm scared to move. You guys with that? What that's like? You know? So Dad says, the dad script. Son, you're a good guy. You don't need to worry about what your friends think about you. Now be Alex, did that change anything for you? You're still stuck, right? So I said, Dad, can I help you out? So I get down on the next to Dad, and I look at Alex, and I say, Alex, so true attunement is not just empathy. Let me tell you this. True attunement is you slow down. And when you figure out how much you need to slow down, you slow down more. And you try to get in their internal world into your internal world, and in that rhythm, and you let their internal experience inhabit you. That's what attunement is. You've been inhabited by their experience. That's not empathy. It's physiological. It'll burn you out if you do it with the wrong clients too often, da-da-da-da-da-da. So I'm going to give you permission on that. So I get on the knee next to Dad, looking at Alex, and said, let me help you out. And I said, Alex, it hurts my heart and I feel it in my gut that you've been longing so much to connect with your friends, that you've really wanted to connect so badly, and I've never known that you've had that desire to connect. And not only that, that you're petrified, you're scared, and you're calling on all of your courage to try to make that connection occur. And I'm proud of you for trying so hard to make that occur, and I'm sad for you that you've been in that pain, and I'm sad that I've missed it. Do you feel any movement from that? I didn't say, go exercise, go meditate, don't care what your friends think about you. I'm just like this. I attuned. I get your internal world. That is the desire for our clients. What unsticks our clients from their development? Someone saying, I feel you and where you're stuck. I get it. And it's not just us saying it. They have to have the experience that we really do get it. You know? That's what the subjective experience of it is. And that's how we see wellness start to occur, is when they have those true attuned experiences, and then we work with that family system so much that they learn how to offer that up at some point. So we have phase 1 and phase 2 in our program for families. Phase 1, all the straight up old school disease concept, Minnesota model stuff. Quit your enabling. It's a disease drug test. Here's how you do an intervention letter. Here's the family session we're going to have. Set your limits. We spend a lot of time on that because we can't get anywhere towards wellness until that's in place. But that's where most programs stop. We're like this. In phase 2 of our program, here's 6 hours of education, parents, plus we're going to work with you in family sessions and on and on and on, is about developmental psychology, about secure attachment, insecure attachment, and attunement, and why it's important, and where you got, and this is probably a 100-year-old issue in your family, so there's no shame in the game, and talk about a case like that in just a bit. That's where we're trying to get people well. I am not interested in a client getting 6 months sober and then being out of our program. 3 months, 2 months sober, and because they come from a highly successful family, they feel the press unconsciously to get back to work and get back to school, which is a house of cards, but they don't want to see themselves as sick, and they want to show their family that they're not sick. So if I just get back to work and school, I'm going to be okay, and that folds in less than 18 months. You know, we see all the summertime stuff right now. What we get these clients right now, like a couple of times. Every summer it happens. We're getting them right now. My kid's going to college in 2 months, and he's been using drugs for quite some time, and I was wondering in this 2 months if you could make it to where he's not using in college. Are you kidding me? We got guys we've been working with for 9 months that are sober, that should not be going to college, let alone your guy. 9 months of sobriety in individual and 12-step and in a recovery group. That should not be going to college. And sometimes with those 9-month sobriety guys, they go in August, September, and we see them again in January because they've blown out. We want wellness, not just, I'll look good for a minute. this other case on attunement, I'll just give you an example. So Jessica and I, we were working with, this is a gift. Was a first for me, Ricky Townsend. 3 generations in the same room. Grandpa, dad, identified client is the dad, and then his 3 kids, 1 boy and 2 girls. And we had it was like a big multi-generational family session. And we're talking about all kinds of hurts and pains. Now what's nice is the psychological mindedness of the grandfather, because he's like this. I'm an ACA guy, adult child of an alcoholic, and I've done some ACA work. My dad was alcoholic and narcissistic. And I get that I've probably got some of the narcissism myself and maybe have passed that on to my son and maybe our kids, grandkids. So that was awesome, because otherwise, you know, it takes a lot of work to show like it's generational. And one of the things that happened in that session, just briefly, they got so this guy, we'll say his name is Sam. Sam's daughter speaks up and says, who's about to just head off to college, really successful gal, and says, Dad, I was really upset at the airport when you were supposed to have my luggage and you weren't there and I needed my luggage. And and he's like, but you know, I showed up and I knew we could buy it with the credit card, so I bought you some new luggage. So I just knew that, you know, we could buy the luggage. They got more money than anyone needs, right? And so then she like quiets down with it, because that's what they're all used to. And then I think it was maybe Jessica's like, could I ask you a question? We'll say her name is Alice. Alice, are you upset that Dad wasn't there with your luggage? And she's like, yeah, I am kind of upset and hurt by that. And what does Dad do? But honey, you knew I could just buy luggage. So then what do I do? Can I help you out, Dad? And it was funny because he's looking a little uncomfortable. Jessica's over here and she's like, don't worry, this is where the help begins. It'll be okay. Which was kind of cool, like on the fly, like that, you know. So Dad's here and I'm like, so I look to the girl and I'm like, honey, I hear that you're hurt because you were relying on me to be there for you, and I wasn't. It was another injury in our relationship. It was another injury that I've tried to minimize and discount, and that you've been just kind of brushing it under the rug, and I'm starting to hear that you have hurt and anger about it, and that in that situation you were frustrated and angry and hurt and whatnot. And then she's like, yeah, and then, you know, can say more now, and then Dad starts to get it more. So it's one of those type of families, right, where they have all the money in the world, but the injuries are deep, and there's no connection, and yeah, he's dismissive, avoidant of me, but I know he wants what's best for me, right? So now it disconnection. So anyway, I just wanted to give you a couple of case examples of attunement versus just empathy. Any questions about that? Oh, good. We got a little time left too, because I have some stuff, other stuff I could share. On my website, so now you get me on a soapbox now. On my website, on every single page of my website, until November 3rd, on the left-hand side is a link that says, read before you vote. Marijuana. I do a lot of talks on heroin. I do a lot of talks on different drugs. And here's what I will share with you. If you want my perspective on the heroin epidemic that we're in, it is, we've enabled it. Addicts do not hit bottom until the system hits bottom. Soak that in. Addicts do not hit bottom until the system hits bottom. And sadly, most of us in our society don't understand addiction. And what we do understand comes from the media. And all of you who took graduate school classes didn't really get held to take really good addiction classes. Addicts don't hit bottom until the system hits bottom. The drug bias that we have had forever is the issue. We have a drug bias. Merv, who is not in our field, are addicts hooked on, what are they hooked on?
Addiction.
They're hooked on addiction. They're hooked on intoxication. We do not have heroin addicts that we're working with. We do not have marijuana addicts or alcoholics or benzo addicts that we're working with. We are working with people who have a pathological relationship to intoxication. That is all we're working with. If we see it as heroin, marijuana, alcohol, whatever, that is a problem. That is a problem. And let me help you through this problem. The name of the drug is all an illusion. Let me ask you this. Which drug is my client using that I assessed last week? Since they've started using, they've increasingly used more and more over time. Their money's gone to it. Their allowance, their wherever they're getting money. Now they're starting to steal to pay for it. Their families expressed concern and set limits. Their friends have pulled away from them. They've got only friends that are using now. They dropped out of sports, fallen out of school. They don't care about work, on and on and on and on. What drug are they using? I just listed some DSMs, you pick the DSM, 3 to 5 symptoms of abuse and addiction. That could be marijuana, that could be heroin. Now, so we don't need to be getting caught up. The similarities, there's more in the similarities than there are in the differences. We get caught up in the small differences of the biology and withdrawal. What happens when your marijuana addict client starts getting drug tested by probation, you or their parents? Do they get clean? That marijuana addict, do they stop using it or do they switch to another substance? They switch. And they will tell you that if you ask them. Because they were never hooked on marijuana. They're hooked on intoxication. When I got my OxyContin addicts off of Oxy, they were benzo addicts. When I got them off of Oxy and benzos, they were pot addicts. When I got them off of Oxy, benzos, marijuana, they were alcohol users, using the alcohol. That is how we have to see this. The bias, addicts don't hit bottom until the system hits bottom. And we have a bias. So I ask you to go inward real quick. Think about someone you love the most, that you would protect the most. Your child, your grandchild, a cousin, a friend, a neighbor, whoever. Hold them in your mind. And my friend right here, Officer Merv Screeton, calls you and says, that person has just been busted at the park drinking alcohol. Sit with that. What's your visceral experience? He calls and says, hey, we just rolled up on that person using marijuana. We just rolled up on that person using ecstasy. We just rolled up on that person using mushrooms. We just rolled up on them using heroin. Do you see your own bias? I mean, probably with the alcohol and marijuana, you're like, all right, this lecture is going to be over at 1:30, and then I'm going to have to go deal with this. Heroin, I'm out. That's the bias. That is the issue we have to address amongst ourselves as clinicians. We have to get the word out that we can't participate and enable the drug bias anymore. When we list the symptoms of addiction, us trained professionals can't delineate which drug we're talking about. We know that the addict comes through the door addicted to their drug of choice, but if we say, you could get out of here but never use that drug again, they're going to go find another substance. So they're not hooked on that substance. They're hooked on intoxication. Heroin, I've talked to the media, I've talked to the clinicians about this. If you've been watching since January the State of the Union address by Obama, who did a great job saying we have an opiate epidemic. Third thing he mentioned in that lecture. Third thing. That's great. And now if you've been having fun watching the entertainment and cartoons of the last year, the GOP, they're like this. In New Jersey, we have heroin. Wherever they're doing their speeches, we have an epidemic of heroin. Then you got the DNC and Hillary and Bernie and all those others that were there. Wherever they're campaigning, we got a heroin epidemic. And then what do they all converge on and saying the problem is from? What are they all saying the etiology is? Doctors are overprescribing. That is so that's so out in left field. Of course there are people that have auto accidents and multiple surgeries and get prescribed painkillers, and some of them get addicted. But when I survey clinical directors and pain management CSAM certified medical doctors from the programs that I know, because I did that before I went and gave this talk that I'm about to say to you, because I wanted to make sure that my data were accurate, 95% of the heroin addicts that we've dealt with, OxyContin addicts, Opana addicts, Dilaudid addicts, were already addicted to something else before they tried that darn opiate. But no one was intervening then. President Obama wasn't talking, politicians weren't talking about it. It wasn't in the media, it wasn't in the news. So we have enabled marijuana. Today, Angela and I were working out at the gym at Lafayette Park Hotel, and there was a gal there, and we said what we were doing and why we're here. And she's like, what's your thoughts on the opiate epidemic? And I said, well, yeah, I think it got enabled from a marijuana epidemic that's been there since the 60s. And the only thing that's changed is the marijuana is more potent, and it's higher, you know. I was addicted in the 80s when it was 5% THC. No client you represent has smoked under 23% THC, and most are using concentrates, which are 70 to 90% THC, and we're seeing psychotic breaks and psychosis and all kinds of stuff nationwide and globally. She's like, marijuana? Really? Marijuana? That's the problem. It should be, really marijuana? You need to go get some help. You know, that kind of thing. But if it's heroin, she'd be like, go get some help. That's the bias. Addicts don't hit bottom until the system around them hits bottom. If Officer Merv pulls over someone and says, look, this is weed, get the heck out of here, but this is heroin, I'm taking you in, that is system enabling. If there's drug and alcohol programs, because there are, that say, oh, you're smoking weed like twice a week and that's it, you should just go home, parents, sorry, that's not a problem. That's enabling. We've had to deal with it in our program where other programs are kicking them out because they don't think it's bad enough. Insurance companies saying, you know, well, you don't meet criteria. What the heck? It's easier to prevent symptoms than to try to reverse them. So we have to intervene earlier. We have to let go of our prejudice. We have to educate more that they're not hooked on drugs. They're hooked on, like what Murph said, addiction. They're hooked on intoxication. That is what the illness is. You guys with me on that? Any questions about that? If you go to my website, recoveryhappens.com, and you click on newsletters, and you click on a newsletter titled The Paradigm Shift That Needs to Happen Now, that was published nationally in Counselor Magazine in greater detail than what I'm explaining to you, because we just don't have enough time.